Welcome to Abdominal Assessment. This section contains assessing the abdomen as well as elimination. The abdomen contains the stomach, small intestines, liver, large intestines, gallbladder, pancreas, spleen, kidneys, and urinary bladder. The abdomen also contains the female reproductive organs. The abdomen can be thought of in 4 quadrants. We have the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. We use this order when we assess the abdomen because it follows the flow of the large intestines. The large intestines start in the right lower quadrant and move clockwise, ending in the left lower quadrant. Always assess the abdomen in this flow so you're consistent and that you can remember what you're hearing where you're assessing. For instance, if the patient has tenderness in the right upper quadrant, you're going to document that and notify the provider about tenderness in the right upper quadrant. The provider will know what organs are in the right upper quadrant and it will help diagnose the problem. The picture on the slide lists what organs live in each quadrant. Now remember, our bodies are not perfect and there will always be variation person to person, but unless we have in-depth diagnostic imaging, we have no idea what these variations are, so we assume that everyone is like the picture unless we have confirmation that they are different on the inside. When we assess the abdomen, besides always following the right to left flow, we also do our assessment techniques in a certain way. We start with the interview, asking our questions, then we inspect, auscultate, then percuss, which is an advanced skill not taught here, and then we palpate, always. If we deviate from this process, we may alter the assessment findings. Because the abdomen has so many organs, we ask a lot of questions. We want to know about any abdominal pain or tenderness, any nausea, vomiting, or diarrhea, any food allergies or intolerances, and their normal diet habits. We also want to know about their bowel habits, including when they had their last bowel movement and the consistency and odor. This question can be as simple as, was your bowel movement normal for you? This information helps us understand the digestive system. To assess the urinary system, we can ask about any flank pain, which is pain in their lower back, urination habits, color of their urine, pain with urine, any urinary infections, and for biological females, we want to ask about menstruation history. For biologic males, although the male reproductive organs are on the outside of the abdominal cavity, we can still ask about it here. We can ask about difficulties with the erections and if there are any lumps or bumps on their testicles. For all abdominal systems, we ask about any surgeries, pain, infections, or trauma. When we do our physical assessment of the abdomen, we need to expose the patient's abdomen. We lift up their gown or shirt to expose the abdomen, and we lower any parts of underwear or pants to expose the lower abdomen. We keep the perineal area covered with a sheet or a blanket. Please tell the patient you're going to do this before you do this. Once exposed, we're going to inspect the abdomen for color, contour, symmetry, rashes, and scars. The abdomen should be symmetrical, both sides looking the same. If there are any masses or hernias causing changes to the symmetry, that would be an abnormal finding. As far as contour, abdomens can be flat, scalloped, or concaved if they're really thin, or rounded and soft. If the abdomen is rounded and firm, then that would be an abnormal assessment finding. Really rounded, starting to look pregnant type of rounding is called distension. The picture on the left shows the different types of abdominal contour, and we want to look at their umbilicus or their belly button for any protrusions or inflammation. Now, we don't normally go inspecting genitalia. We only go inspecting if the patient has an issue and we need to inspect to help diagnose their issue. It isn't discussed in the book, but it's not part of our normal nursing assessment. When we auscultate bowel sounds, we need to make sure we're using the diaphragm or the stethoscope as bowel sounds are relatively high-pitched. Place the diaphragm lightly against the abdomen wall and start in the right lower quadrant and move clockwise, following the flow I mentioned before. We're listening in each quadrant until we hear bowel sounds, which are like stomach gurgles. The gurgles occur every 5 to 15 seconds if they're normoactive, and those gurgles are the air and fluid moving around in the small and large intestines. Once you hear some move to the next location and listen there until you've continued listening in all 4 quadrants. There are a couple of abnormal findings for bowel sounds. The first is absent or no bowel sounds. The book says to listen in each quadrant for 1 minute or longer to say that there are no bowel sounds, but I'll tell you that if you're going to call a provider and tell them that there are 0 bowel sounds, you better be very sure. I listen up to 5 minutes per quadrant. Absent bowel sounds is a medical emergency, and you better be sure there are no bowel sounds. Hyperactive bowel sounds would be bowel sounds that are occurring way faster than 5 to 15 seconds. Think of this as your abdomen is just churning and turning like you have a really, really bad upset stomach and have diarrhea. That would be hyperactive bowel sounds. And I bet some of you are nodding your head and know exactly the sounds I'm talking about. Hypoactive bowel sounds are when the bowel sounds are occurring less than every 5 to 15 seconds, but they are present. You hear some noises. And this is very common after surgery or some medications, but could also be a sign of a disease process in the abdomen. So regular, non-advanced practice nurses only do light palpation. Advanced practice would be going in and feeling deeper, like trying to feel organs and masses, but regular nurses do not do that. To do light palpation, we're going to start in the right lower quadrant and move clockwise, using 2 to 4 fingers to gently press on the abdomen and rotate our fingers in a gentle circular motion. And by gentle, I mean like 1 to 2 centimeters deep. We're barely pressing. We don't want to cause pain. Every time we do this, we need to ask if there's any pain or tenderness with our palpation. Or we're going to repeat this in the other 3 quadrants in the flow we've already mentioned. We're checking for tenderness, and we're checking to make sure the abdomen is soft and not firm. Now, if we think the person is tensing their muscles and that's why it feels firm, we need to get them to relax. Firm abdomen is an abnormal sign, so we need to make sure it's truly firm and not them tensing up. There is one caveat to the normal flow of our assessment. If the patient told us they have abdominal pain in their interview, we want to palpate the painful spot last. Once we press on the painful spot, they're not going to want us to continue pressing anywhere else, so make sure that spot is last when you assess the entire abdomen. Because Block 1 focuses on adults and older adults, it's necessary to discuss common variations of the abdominal assessment in older adults. Older adults may have decreased bowel sounds, either hypoactive or we just can't hear them well. This is because they tend to accumulate adipose or fatty tissue around their abdomen, and adipose tissue is hard to hear through, and also the bowels slow down as we age. Older adults also take a lot of medications that may decrease the movement of the intestines. And this is the end of part 7, abdominal assessment.